Hello, everyone. I'm Gena Elassall. I'm the chair of Research and Innovation Office in MTOG and the director of the fellowship program. Now I will be with you to present our systematic review and meta-analysis for ovarian cancer. Actually, it is the very first paper for our fellowship program. It discussed the prognostic value of systematic lymphadenectomy in patients with ovarian cancer. We know that ovarian cancer is the 7th most common cancer in women, and it actually has a special or a very bad effect regarding the mortality rate. More than 50% of cancer-related female deaths worldwide is caused by ovarian cancer, and that only because of the late diagnosis. Standard treatment is known to be primary debulking surgery with chemotherapy, and neoadjuvant chemotherapy is stated in Society Gynecologic Oncology and the American Society of Clinical Oncology Clinical Practice Guideline. In case debulking is unlikely with primary surgery in stage 3C or 4. The part we are discussing in our study is the use or the prognostic value of using lymphadenectomy with ovarian cancer patients. We know that lymph node metastasis is reported in about a range of 6% to 40% of women within the stage 1 and stage 2 of the disease. However, many studies fail to solve the debate of the significance of systematic lymphadenectomy on overall survival of cancer patients, involving a recent trial that was published by Dr. Harter in 2019, which we call LION, which was on 647 patients with stage 2B and 4 of ovarian cancer. Systematic lymphadenectomy is still a debate to whether it should be stated as a routine part of debulking surgery or not. In our study, we studied this debate or controversy not just to solve it, just to find what is behind this debate and to analyze this controversy part. Our method was that we conducted a systematic review that included all the comparative studies that assess clinical outcomes and prognostic values of systematic lymphadenectomy, regardless of the different factors that could affect or could be stated as a contributing factor of comparison, whether they are disease stages, chemotherapy, or control group, either no lymphadenectomy or they did selective lymphadenectomy. We targeted our primary outcome related to the survival rate. Here we are talking about overall survival and progression-free survival, and the secondary outcome were intraoperative complications and postoperative complication, including operative time and hospital stay, as well as the secondary outcomes. In our data abstraction, we included all the characteristics we could have in the different spectrum in all the papers, including characteristics, surgical management, tumor characteristics, and lymph node status, residual disease, types of chemotherapy, type of surgical maneuver, and different times or duration of follow-up. When we came to the analysis part, we find 3 things. We are collecting all the comparative studies, whether they are RCTs or cohort, either retrospective or prospective. So we have a wide spectrum of different study designs. So what about the heterogeneity? Is there a heterogeneity in the data? Are they homogeneous or not? And we also have the controversy part itself, that the literature didn't actually find a conclusion or a definite answer to whether we can use systematic lymphadenectomy in ovarian cancer patients or not. And there's a part we are speaking about, which is the matrix. What is the matrix? What I mean about it? It's gonna be discussed in the further part. So we resulted the following. It's just an overview on the results. I'm not gonna talk about the details of the characteristics of each paper, but just to overview, we eventually had 22 comparative studies that met our criteria. Of all these studies, 19 were retrospective cohorts and 3 only were RCTs. They concluded different stages, different grades, different disease characteristics, and different maneuvers or management approaches, including different management approaches in surgery and usage of neoadjuvant or adjuvant chemotherapy. But 15 of them were conducted multiverse Cox regression analysis of overall survival, and all of the 15 were eligible for our study analysis. So most of these papers had actually a data regarding our primary outcome. We find or we stated a new novel matrix or a new novel method of expressing an illustration of our analysis called triple M, MOOC meta-analysis matrix. What does it mean by the matrix? We have, as I stated before, we have a wide spectrum of study designs, including retrospective and prospective cohort and RCTs. This creates a heterogeneity to the study, not just itself, but it was one of the major causes of heterogeneity in our study. So, to solve this heterogeneity, we made this novel illustration tool that used to present all the possible and multiple subgroup analysis we made because of that heterogeneity that was in the cohort studies, using 3 axes or 3 different parts in the study. The 3 different factors in our study. The first was the stage, which was the upper row, the stages of the disease. We categorized our studies, our analysis, according to the different stages was stated in every paper we included in our study. And the right part is the type of chemotherapy that we used in the management approach. And in the right portion is the type of the management approach that was used in the control group. Either they used no lymphadenectomy or they used selective lymphadenectomy. According to this, we concluded that our pooled analysis concluded that all the study showed superiority of overall survival in those who had systematic lymphadenectomy, but it was just close to significance compared to the control group. Either the control was no systematic lymphadenectomy or selective lymphadenectomy. But the heterogeneity of the studies was significant. So the matrix solved that significant according to the subgrouping. We made 2 subgroups or 2 main subgroups. The first one that we subgrouped the paper according to the study design, so that the subgroup analysis of the 3 RCT didn't actually show significant difference in overall survival. So the design itself didn't migrate or didn't have a great effect on the heterogeneity. While the parts or the characteristics of the patient that was involved in each study was actually the major contributor to the heterogeneity. We found that systematic lymphadenectomy didn't improve the survival in early stages. However, it was close to have significant effect in advanced stages like 3C and 4, and statistically significant in stages like 2B and 4, whether they are receiving adjuvant or neoadjuvant chemotherapy. So the staging actually is a contributing part to the effect of systematic lymphadenectomy. And it was also most significant regarding overall survival in patients with a stage 3 to 4 when compared to the control group that was having no lymphadenectomy at all. Systematic lymphadenectomy, according to our analysis, also didn't improve survival in those receiving neoadjuvant chemotherapy, regardless of the control group. And it has a significant, or a close to significant effect, whether it was used with an optimal debulking or in the group that used optimal debulking only or optimal and suboptimal debulking. Regarding the progression-free survival, systematic lymphadenectomy was associated with improved progression-free survival versus control in all of our groups or in all of our patients included in our studies. Our secondary outcome was subcategorized to parts: intraoperative part, which included operative time and intraoperative complications that were significantly higher in systematic lymphadenectomy versus control. But when we look to the post-operative part, hospital stay and post-operative complications were not significantly different between the systematic lymphadenectomy group and the control group. So now what? We have a new RCT that was lately published, not our RCT, but the line RCT that I was talking about before, that was published recently in 2019, that stated that systematic lymphadenectomy didn't really have a benefit on the survival of the patients having ovarian cancer. And there is multiple systematic reviews previously that stated that it can have a benefit. So who is wrong, who is right? That was the controversy we are trying to solve. So we made this subgroup analysis so that we can go deeper and find that there is other contributing factor that control this conclusion. So we can just studied superficially. Firstly, staging have an important effect. So systematic lymphadenectomy was actually having a significant or close to significant in advanced stages, while it has no significant role or implement on the overall survival in the early stages. That may be because of different factors related to the less abundance of the papers or the amount of the studies made on the early stage part and involve the systematic lymphadenectomy as well. There's also a proof that systematic lymphadenectomy is actually having a better effect or a significantly beneficial effect on applying adjuvant chemotherapy compared to controversial effects on applying neoadjuvant therapy. That made us take a deeper look on the type of the chemotherapy and the type of the patient responding to the chemotherapy that's used on applying systematic lymphadenectomy. And the last part is the line RCT, or the Harter's 2019 RCT that was involving, or that was concluding that systematic lymphadenectomy had no role in ovarian cancer patients in advanced stages, which is the opposite that we are analyzing. We can go deeper in this study and we will find the following. First, there's some debates about the methodology of the study. First, the median age of the patient in the study was 60 years old with a good performance scale. That means that actually the characteristics of the patients were homogeneous towards being better than others. Actually, there's another part related to the patient characteristics, which was that more than 60% of the population that were stated before randomization were actually excluded according to different reasons. So maybe a part of that big population or big rate of the excluded population could have a worse or poor prognosis, and they were actually be beneficial or have a good chance or a good opportunity with systematic lymphadenectomy. So it's not just that a powerful study or a powerful design concluded something so that it is really good or can be based as a good evidence. We need to go deeper to studies, to go deeper in the analysis and the debate, and to study each study design good to be sure that actually the conclusion is as weight or as powerful as it is. Thank you.
Thank you, Dr. Gena.